welcome to week 4, and now we're going to move into a little bit more of the diagnostic procedures. So if we were on campus face-to-face, we would do this lecture and then spend some time together in the lab, and I'll explain to you what we'd be doing in the lab together. So let's go into a little bit of how we collect the information we're going to need from a patient in a rehab setting. So in cardiac and/or pulmonary rehab, their first appointment once they come into the clinic is going to be spent with you. You're usually called the case manager. So a case manager is either a nurse or an exercise physiologist. We're going to do a medical history, conduct a physical exam, which is oftentimes new, and you're going to learn that during your internship. Take a look at any type of lab work, so invasive and non-invasive tests. What have they gone through? What's the blood work? What are all the findings? Stress test, angiogram, blockages. What we get during this first day is a lot of information, and it says on that last bullet both the history and the actual physical exam is really the cornerstone to evaluating a clinical workup for a patient who we know has heart disease. So understanding for cardiac rehab, that first intake, the more we can understand who they are, their risk factors, family life, their job life, their procedures, the heart procedures they've been through, the better it's going to be. So last week I asked you to read the American College of Cardiology and the American Heart Association document, and I got a lot of emails on like, oh help, I need more direction. What is this thing I'm reading? How do I summarize it? So this is a really important document because it takes everything we know about risk factors and it puts it into practice, right? So we've got the 4 levels, 1, 2, 2A, and B, and then 3, right? The 4 levels. Those levels are derived from research, right? So class 1A, class 2, right? This is telling us research says that class 1 is very effective, should be done, right? So the letters are who should we be doing it on, right? Then those numbers are. The letters A, B, and C tell you what type of trials, right? Everything needs to be evidence-based practice. Evidence-based practice means it comes from research. So if it's at a multiple randomized control trials, right, really nice meta-analysis, that's going to be a level A. If it's more from just maybe non-randomized, it's a B. If it's from case study, more opinion from experts, it's going to be a C. So I wanted you to go through all those risk factors. What do you know, what don't you know, and what's a little bit shocking in what we see out of these. Then I'm going to talk a little bit about who are we, those of you heading on to grad school that want to work in a clinic, some of you don't, but what is a CEP? You know, where do they work, right? So a CEP is someone who needs to understand decision-making process of CVD, as well as all of the diagnostic procedures a patient can go through. We're not doing them, but the best clinician, the best way to train and help somebody is to understand what they've been through. So CEP can provide oversight, lots of education about diagnostic procedures. They ask a lot of questions. Why did I have this test? Well, my coworker had another test. So why things were performed, maybe why weren't they performed. Administrative documentation of cardiac diagnostic testing, and then a lot of questions on prognosis. Is it going to happen again? What should be concerned about? How to manage diabetes, manage cholesterol, manage stress, right? So it's a CEP is definitely more than just giving them an exercise plan, which is what we know, but there's a lot of other layers we want to get to. So when you're in the history, some of the big things we want to understand are the signs and symptoms they complain of. So this box talks about angina pain. Where is it? How do they describe it? Is the angina in the chest? Is it in the neck? Does it feel like a toothache? Is it in the back between the shoulder blades? So you want to ask these questions. Tell me about your angina. Tell me about that chest pain. How would you describe it? Was it crushing? Was it burning? Was it squeezing? Shortness of breath. When do you get it? How often do you get it? Are you at rest? Are you exercising? Do you ever have experiences of dizziness or syncope? Right? When does it happen? Orthopnea, or the word paroxysmal nocturnal dyspnea, right? These are people who wake up, shortness of breath, or with positional changes have shortness of breath. Ankle edema, right? Look at the ankles. Look at the for swollenness. That's a big flag. We'll talk about that later as well. Palpitations, racing heart, tachycardia, intermittent claudication, right? That is number 7 on the list. That's a fancy name for leg pain, right? Leg pain, sharp pains in the leg. Known heart murmur. Has anyone ever told you you have a heart murmur? So when you put your stethoscope on, you know if what you're listening for. And then any other type of unusual fatigue, shortness of breath, with activities, any of that stuff. So again, the cornerstone of your treatment with your clients is data, information. You need to know them, right? So complete history, physical exam, lots of information about what led up to them having a heart attack or open heart surgery, what are their symptoms, describe the symptoms in their own words, describe them. Again, arm, chest, back, jaw. Evaluate risk factors. So know the risk factors, like the sedentary and stress and cholesterol and diabetes and the whole list, right? Get blood work because you want blood work on where they were here in the beginning when they're in the hospital. So what was their latest blood work? And then while you're in rehab together, we're going to send them for more blood work. You got that? So you get their baseline blood work, cholesterol, glucose, any of those things, right? Get all of that, and then we're going to send them again, definitely for cholesterol, another screening around week 8 or week 6 or 8 of exercise cardiac rehab. Measuring as many hemodynamics as we can, so blood pressure, body weight, heart rate, BMI, all of that stuff. And a lot of times at this point, we're going to do our rest, at rest, we're getting all this information, we're getting a physical exam, we also usually need to do a stress test as well. So when you take a look at the components, and again, this class is sometimes a learning curve depending on what you've had prior to leading up to this class, but the medical history has a lot of components, and we would really need to spend time helping you learn all of these. I don't expect you to be able to do all of these. So what medical diagnosis? So you sit down one-on-one with the guy in cardiac rehab. Tell me what your medical diagnosis has been. Was it a heart attack? Was it open heart surgery? Do you have a stent put in? Right. So why? What brings them to you? Previous physical exam findings. Right. What else are they going to share with you? History of symptoms of anything, any type of symptoms. Right. So because they could be battling lots of other diseases, right? Diabetes, they could be a cancer survivor, they could have a list of things. Any recent hospitalization, new medical diagnosis, or surgical procedure, so what have you been treated ever for, even non-cardiac? Ask them about orthopedic stuff, shoulders, back, knees, what hurts them? What have they had maybe addressed by a physical therapist, orthopedic surgeon? A list of medicines that you have to tell them that on the phone before they come to see you. Bring a list of your medicines, the name, how many milligrams you take, and how often a day. You need to know that. Habits, right? So what are the habits that they have? And this sometimes is a little eye-opening. You never know what people are going to tell you on the habits, but it could just be coffee and pop and Diet Coke, a couple glasses of wine, tobacco, how much, right? Are they smoking it? Are they chewing it? Are they vaping it? How are they using tobacco? How much are they using? And then drug use, right? So when you just matter of fact say that, sometimes you realize what people are doing. And a lot of these things we can begin seeing on the EKG and the stress test anyway. So you want to know as much as you can about them. Exercise history. And a lot of times when you ask for the exercise history, they go into this long-winded story of, I once was the quarterback of my high school, and here the guy is, 65 years old, telling us that he once was a high school quarterback, which is irrelevant now. So, let them share with you what they once did. In their mind, they might still think they're active, but they're not. This tells us a lot. When someone gives us the history of what they once lived to do, it helps us when we're making a program to try to tailor it for them. Right? If someone says, I love swimming, I love group exercise, I love weightlifting, right? It helps us to understand a little bit of what our expectations are going to be in the exercise environment. Work history, manual labor, sitting at a desk. Right? What is their body going to have to get ready for? Both are bad, right? Manual labor and sitting at a desk, both are stress on the body. But ask what they do for a living, where we need to get them at. Some of our manual laborers, first responders, factory workers, truck drivers are going to have to pass a stress test before they get released to go back to work. So these are important things to know. So we can titrate the program to really see some improvement. And then family history. You tell us a little bit of the family history. Okay, other things we want to get in that physical assessment is basic size, so body weight. So body weight is going to be done in a hospital based on BMI, whether you like it or not. We're going to be using BMI, right? Waist to hip. What's their waist? What's their hip? Usually we don't have a bod pod on premise, but a lot of times we'll just measure their waist, measure their hips, right? Their circumferences can tell us a lot as well. get their pulse and their rhythm, which we're going to do again when we do the stress test. What is their resting heart rate? Blood pressure in all three positions. We need to practice this in the lab. We need to be good at taking blood pressures. So seated, supine is lying down, and standing, and you're watching to see how it may fluctuate with those different positions. The next one is the word auscultation. This is when you're listening for lung sounds, and this is what I would really want to be teaching you in this class together in the lab. When we auscultate the lungs, we are listening, and the doctor's done this to you, right? They put the stethoscope usually on your back, on a few different spots. Inhale, exhale. We're listening for the sound of breath. It's kind of like a balloon, inhaling, the little sound a balloon makes when the air is going in and out of the balloon. That's healthy. If it's not healthy, you're going to hear stuff, crackles and rails and wheezes, and there's so many incredible videos online that you can now, audio videos, you can listen to what it sounds like when you put a stethoscope on someone's chest in pulmonary rehab, ideally, and you just hear noise. Sometimes auscultation of the lungs can happen without a stethoscope. You may have sat beside an old, bigger size man who was a long-time smoker. You can just hear him breathing, just a loud noise. So auscultation is an important thing we had to listen to. Palpitation of cardiac apial impulse. Again, we do that in the lab, taking a look at the auscultation of the heart. And we also take the heart, different than the lungs. The heart, we're listening for the valves opening and closing, for the opening and closing of the valve, which is always nice if you ask someone, do you know you had a murmur previously, because you know what you're listening for. Again, it just takes training of your ears. We are exercise physiologists. We are not physicians. We are not diagnosing heart murmurs or lung sounds. We are telling them what we think we hear on your intake of your patients. So while they're exercising, if things change, you have a baseline of what you can refer back to. Palpitation and auscultation of the carotid. So you can listen to the carotid artery in the heart, the abdominal femoral artery, to hear that blood swishing through there. Abdomen sounds, so the GI system, lower extremities. Next bullet, really important. You want to palpate with both hands, right and left hands, with your two fingers. You want to feel the inspection of the lower extremities. You're looking for edema, right? Is there pitting edema? Is there a lot of water down there? And can you palpate and grade the pulses? So if you feel them nice and strong, left and right in the legs, on the foot, it's a 4. If you feel them weak, right, you grade it down, 4, 3, 2, 1, 0, absent, right? So you can feel nothing. If someone's full of edema, full of water, poor circulation, you may have like a 0 or a 1. The next one, absence of presence of, we're looking at, skin discoloration, you're looking at orthopedic problems, you're looking at how well they walk, their gait cycle when they walk with you, from one spot to the next spot. Pay attention, always be analyzing their gait cycle, looking at their balance, looking at any neurological issues that could happen with reflexes, basic cognition, again, balance, and then always inspecting their feet, which might sound strange, their feet, with their shoes and socks off, especially for people with diabetes, because they often can't feel, due to neuropathy, they can't feel those wounds that may not be healing. So a physical intake at the first time in cardiac rehab may be a little foreign to you, because you're doing things that you may not have yet learned in your exercise physiology background. So it's important that, especially if someone who had open heart surgery, you take a look at the sternum to see how well that sternum is healed, take a look at where they've removed the veins and how well that tissue is healed, lots of things that we want to be noting. So when you're talking about the medical diagnosis, in the beginning, I had that on an earlier slide, we're looking at what is your diagnosis. Most commonly, it's going to be CAD, heart disease, MI, revascularization, open heart stent, a valve, could be congenital, a rhythm, left ventricular dysfunction, or they could have PVD, peripheral vascular disease, that's a hardening in their legs, or CVD, which is a stroke. So it could be any of these, it could be a multiple combination of them, it may just be one as well. And also, when you ask them for a diagnosis, remember I told you earlier, gather as much information as you can. So any of the others that may be on this list, tell me about it. When were you diagnosed? What did they do? So you're kind of really, in the chart, making quite a long summary of a lot of information about who this person is. Remember, height, weight, BMI, waist circumference, blood pressure, pulse rate, heart sounds, right? Can you listen to the heart sounds with the stethoscope? Peripheral pulses, palpate them and feel the pulses in their extremities. Look for edema, pulmonary findings, and if you can, see the chest X-ray, that's great as well. Electrocardiogram may be sent to you, urine, blood glucose numbers, blood lipids, and lipoproteins. So this slide, a lot of this stuff will be sent to you in rehab from when the patient was in the hospital. So you get all this baseline of where they were when they were this ill in hospital. And then you get them going on the exercise program. Like I said, about 4, 6, 8 weeks later, we're going to be allowed to send them for another round of blood draw. And ideally, we really want to look at their lipids, their cholesterol levels. You will do a stress test and electrocardiogram on day 1 of cardiac rehab, and then again upon exit. So GXT, grade it, treadmill, stress test, right? Electrocardiogram, however you want to know it, right? Treadmill walking. Day 1, they come to exercise with you for, 8, 10, 12 weeks, 3 days a week, and then we do it again upon exit. So we have pre and post. We're looking for outcomes, right? Healthcare is all based on outcomes. Where were they? What benefits did you make? Outcomes on cholesterol. Where were they in the hospital? Where are they now about a month and a half later with their cholesterol numbers? Glucose, the same thing. Okay, so when you think about symptoms of chest pain, right, you're trying to gather this information out of that medical history. These are all the words they may mention. I kind of mentioned them earlier to you, right? So tell me what you felt like. They're not going to use the word paroxysmal nocturnal dyspnea. I'm not going to throw that word out to you, but they're going to give you symptoms. You're planning to use the word syncope, right? So you want to ask them that question. Tell me how you felt leading up to going to the hospital. Tell me how you felt leading up to having a heart attack. Knowing that these are kind of the symptoms, these kind of classic 8 symptoms that we're looking to see, did they have, how did they describe them? Because if they're going to have another episode, it's usually going to be similar. Right, so history of symptoms, we get this because while we're pushing them and exercising and training them, we want to really keep our eyes open and monitor to see if these symptoms are going to reemerge for another episode of, another blockage in the heart, another MI. So chest pain, dyspnea, palpitations, transient loss of speech, numbness anywhere, fatigue, all of our classic things. Again, what medicines are they on, both for their heart and non-heart related? Are they on any illicit drug? And you have to ask this because drug use will change the EKGs. And so you're going to be able to tell, and I'll show you, especially if any of you are in my graduate class for EKG reading, we'll look at what it looks like on an EKG if someone's got some substance in their body. Vitamins and herbs, you need to ask them. There's a lot of things you can buy at GNC or the grocery store that will actually harm when it interacts with a chemical agent from their medicine. So not all vitamins and herbs are recommended for heart patients. You want to make sure, and in cardiac rehab, we always have a pharmacist that comes in and helps answer these questions, because the chemicals they're on, the medicines are chemicals, they're on a lot of times the natural substances, and certain doses and certain combinations can become very problematic. Okay, so I kind of went over all of this right in the other slide, right? Family history, lifestyle, what do they do, when do they sleep, how many hours, what type of food do they like to eat, what do they like to do for enjoyment, how many minutes and hours are they spending in the chair, do they have exercise equipment at home, why do they not exercise, what motivates them to exercise, right? All of these things, because you are going to make a lifestyle program change for them. You're going to make a long list of goals and how you're going to reach these goals and hopefully revamp who they are, right? Reading food labels, meal planning, understanding how to really take a look at their stressors and make change. When we talk about angina pectoris, I've used this word a lot, right? They're angina symptoms. It is really the most important goal of our history is for you to identify what that felt like. So we know what angina is. It's ischemia, right? Inadequate perfusion of blood to the endothelial, myocardial, epicardial layers of the heart. So an ischemia means that there's a block in that artery, the blood's not able to get through, and now that ischemia makes the symptom angina, right? Ischemia and angina, same kind of thing, right? A heart that has ischemia, not getting blood flows, usually the body's going to start producing angina. Angina happens at different times of the day. It can happen when you're sleeping. It can happen when you're shoveling the snow. Angina feels different to different people. The symptoms are not always the same, right? Right versus left side, pain versus pressure, squeezing. you really want them to use the words that they describe. So just have them, with their own words, describe what those symptoms felt like. What made them not feel good, what made them think, gosh, this could be their heart. Write it in their chart, because usually angina symptoms are going to, if they're going to reemerge, they're usually going to reemerge with similar kind of symptoms, symptoms or descriptions of how they describe what that felt like. On the wall in the lab, you see we always have an angina scale, 1 through 4. It's kind of like a pain scale, 1 through 10 pain scale. 1 through 4, 1 being light, 4 being the worst ever. So when someone gets to 3, we have to stop exercising them. We know that while we're exercising. So we want to be aware of that. When someone is in a cardiac rehab and they begin getting angina, we have a prescription right there to give them to use a medicine called nitroglycerin. Nitro is commonly abbreviated nitro. It's a tiny little pill, sublingual. It goes under their tongue, and it's just going to dissolve. And as it dissolves, it vasodilates, so that artery that was nice and tight, it's going to vasodilate and open. And now that vascular smooth muscle is going to relax, and they're now going to get blood flow. We are allowed to give multiple nitros. So take 1, make sure they're sitting down, off the machine, sitting down, because they're going to get lightheaded. Commonly, it's a vasodilator, so everything vasodilates. Nitroglycerin can save us time so they don't end up having a heart attack. Oftentimes, patients may be prescribed nitros in a little bottle, oftentimes attached to their keychain, but they're afraid to take it. That's just bad education, but they're afraid. They shouldn't be. In rehab, we can give them nitros. Sit them down, take 1, wait 3 minutes. If they still are giving you angina here rated on the scale, give them another one. And if the second angina isn't working, you need to call for help. So, if you're in a gym, out, Planet Fitness, call 911. If you're in a rehab, you're going to get them help. The more minutes they're ischemic, the more minutes they have angina, the time is muscle, the more heart damage is going to be done. I talked about cardiac auscultation, so listening to the heart sounds. Again, in the lab, this is something we would need to practice. So our heart makes 2 sounds, lub-dub, right? Good, healthy hearts make 2 sounds, lub-dub. When you have heart disease, and after years of long-standing hypertension, a lot of times you have more than just lub-dub. So we want to be able to help you understand how to hear heart sounds. Again, this is a online class, so I can't help you listen together with a double stethoscope, but I can tell you that we have some great video resources to listen to just so you can hear. But rest assured, if this is the path you're going to take for a career, you will learn this in your internship. I hate to throw it out onto the practicum internship people, but that is really when you get this best practice. Because if we're in the lab, most everyone in the class has got only lub-dub anyway. We only have S1 and S2. We're not going to hear an S3. We're not going to hear an S4 because we're all healthy. So there's just something to be said for the clinical internship at helping you. So abnormal heart sounds can be lots of things. Again, we're not here to diagnose heart sounds, but I'm here in this lecture to say taking an assessment, doing an inpatient and intake, you need to make sure you're noting what you see on day 1. Right? And you'll get good at doing this as you go through an internship. Peripheral pulses, right? So again, I mentioned that earlier. If someone has PVD, peripheral vascular disease, intermittent claudication, it means they have blockages in the arteries in their legs. You want to take your 2 fingers and you want to palpate down by around their feet, around their shin. You're trying to feel for a pulse. If the pulse is weak, then we know we have problems. But those are in the legs. We also can take a look the carotid, the brachial, the radial. You can palpate all of these arteries to listen and feel the force of blood. How strong is that force of blood? A bruit is when you listen with a stethoscope to hear the turbulence of the blood flow going through those arteries. So carotid bruits are high-pitched. That carotid bruit up here that oftentimes is going to lead to stroke. Palpitation in the legs is what we know PVD that leads to intermittent claudication. I have a fancy word for leg pain. So a lot of language that hopefully it brings back memories of medical terminology. So we are not going to do lab tests, but we're going to get lab tests, right? So you're going to be able to look at someone's chest x-ray. You're going to look at their baseline EKGs. You're going to be able to see what their EKG looked like before they had their heart attack. See if they have any underlying arrhythms. You know, do they go into AFib? Do they have a bundle branch block? The other thing that's interesting is the blood work that's done that diagnose them for having a heart attack. We call those cardiac enzymes. So when someone is coming via an ambulance or a squad into the emergency room, one of the first things we're going to do is draw blood, because as the heart is stressed during ischemia, that leads to a heart attack, right? They're having angina pain. They draw the blood to look for the cardiac enzymes that are beginning to float in the extracellular fluid, and that's going to be able to tell them that there's necrosis, cell death. So if there's cell death, they're going to be able to look at those blood values and see that the damage that's happened. So this is kind of a cardiac markers. Again, we don't do this, but this is, I just think, really interesting when we talk about, this is my dog beside me, scratching his head. Cardiac enzymes are proteins, again, that leak into the extracellular fluid during stress, during ischemia. And again, if you may have mentioned this in an earlier lecture, if you watch enough ER and House and those kind of TV shows, you probably have heard some of creatine kinase and CKMB levels. These are all things to quickly help diagnose what's going on. If there is a heart attack, we call it necrosis. The cells died, and based on the levels of the enzyme, the doctor can actually tell how much time has passed. So the more time that passes, the more heart muscle is dead. It dies. So myocardial infarction has occurred, then we have more elevated, and we have a more precise diagnosis. There's a lot of information. So this week is only Quest 1. Quest, a quiz, not quite a test, simple, open book, go through the lectures and be able to answer the questions.